Okay, so this is a 31-year-old female where her original weight was 110 with BMI 45.2. The patient had no previous comorbidities and she had a history of laparoscopic sleeve gastrectomy in 2010 where she reduced her kg down to 65. Her BMI at that time was 26.8. In 2014, she presented to Dubai Hospital. She gained weight. She had less restriction, so the patient underwent laparoscopic Roux-en-Y gastric bypass, where she reduced 10 kgs. The patient was following up regularly in our clinic, and in 2017, 3 years after the gastric bypass, she started to complain of vomiting, nausea, and reflux for a few weeks, and she was unable to eat solid food, even if it was small particles. At that time, her BMI was 29. So she was at that time already on pantoprazole, and it was from OD to TDS, but it was useless. So the patient was admitted to the hospital, and the main complaint was severe reflux and vomiting. She underwent laboratory testing. She had no iron deficiency anemia or vitamin D deficiency, and she underwent an upper GI endoscopy. We found that she was having a sliding hernia, incompetent cardia, and H. pylori was positive. There was no esophagitis and no ulceration. Further investigation and imaging was done for the patient. This is a CT scan of the abdomen and pelvis, which showed the sliding hernia, and you can see the stomach and the clips from the sleeve, and the jejunum and the ileum was normal. There was no internal herniation. This is another slide. So upper GI series was done for the patient. There was free flow of the contrast media. There was no holding up or gastroesophageal reflux noted there. And small sliding hernia was evident. So we were thinking, what can we do to offer this patient to relieve the severe reflux the patient which was having? Whether to continue on conservative or to go for a surgical correction. And we had multiple choices: chloroplasty, repositioning of the sleeve, band application over the gastric pouch, adjustable or non-adjustable, or to go for other procedures such as health procedure, ligamentum teres, cardiopexy, endoscopic approach, or any other solution. So we went through the literature. We had health operation and yes, and management of the gastroesophageal reflux post-sleeve gastrectomy. A lot of articles, a lot of options were there, and finally we decided to go for a diagnostic laparoscopy, and this is the procedure. And the ligamentum teres there was found short for the preparation, so we went further for releasing the adhesions. And the decision was done to go for